For our best evidence topic, we chose to research Wilbarger's protocol in children with autism. This was done by Sarah Abrasheff, Amanda Cadena, and Jessica Irvin. For our clinical scenario, we chose to use Allie, a 2.5-year-old girl with autism spectrum disorder. Her parents were feeling very overwhelmed by her behavior and chose to have her assessed by an occupational therapist. Her symptoms included emotional outbursts anytime she was changed, brought into a different room, during bath time, and whenever water was touching her. As a coping mechanism, Allie would fall into a deep sleep after exhibiting those behaviors. Through the occupational therapist assessment, it was determined that Allie was exhibiting severe sensory defensiveness, and the treatment of sensory integration and Wilbarger pressure protocol would be most helpful. After reviewing this clinical scenario, we came up with the evidence-based occupational therapy question as follows. Is using a combination of Wilbarger's TheraPressure protocol and sensory integration therapy more effective in improving sensory tactile tolerance of water-related sensation during self-care for a 2.5-year-old girl with autism spectrum disorder and severe sensory defensiveness, as compared to standard sensory integration therapy alone? For our summary of evidence, appraisals, and key findings, we were able to uncover 3 themes in all of our articles. The first one is treatment fidelity, the second, statistical efficacy, and the last one, clinical appropriateness. For the summary of levels 1 and 2 in the treatment fidelity theme, the studies reviewed showed a lack of fidelity among therapists who were implementing the Wilbarger protocol. For statistical efficacy, the sensory integration was significantly more effective than the usual care for children with sensory defensiveness. And for clinical appropriateness, there was no level 1 or 2 articles that had this theme. For the summary of levels 3, 4, 5, and qualitative, for the treatment fidelity theme, the review of articles in this theme show a lack of overall treatment fidelity. And this was shown in multiple articles that we found. For statistical efficacy, articles revealed sensory integration approach was effective on children with autism spectrum disorder. A significant correlation was found between self-care ability and sensory processing disorder in children with autism spectrum disorder. And observation is the primary method of effectiveness of the Wilbarger protocol. For the theme of clinical appropriateness, for the summary of levels 3, 4, 5, and qualitative, caregivers ranked the Wilbarger protocol high in importance and information satisfaction and wanted to continue with the interventions despite the negative impact on daily routine and inconvenience. Also, several studies in this section reported clients' negative reactions to the brushing protocol. These negative reactions were used as a key deciding factor in discontinuing use of this aspect of the protocol. Also, both occupational therapists and caregivers reported difficulty in incorporating the protocol in daily routines. A correlation between self-care and sensory processing disorder could indicate that sensory integration approach is an appropriate intervention. And finally, stereotypic behaviors of autism spectrum disorder are the behavioral output and observable components of sensory processing disorder.
Prior to our research, we understood the Wilbarger protocol to be separate from the sensory integration approach. However, we have found that the Wilbarger protocol is in fact a part of the sensory integration frame of reference. The Wilbarger protocol provides tactile stimulation that uses a brushing technique, but was not established to provide other types of sensory input. There is a general lack of understanding regarding the Wilbarger protocol, which makes it difficult to determine its effectiveness. Despite this, sensory integration and Wilbarger protocol are popular interventions among occupational therapists in treating sensory processing dysfunction. There was found to be a link between sensory processing disorder and self-care abilities in children who have autism. Caregivers ranked the intervention as important to their child's goals, despite the difficulty in incorporating it into their daily routines. In performing our evidence search, we utilized the PICO method, or Patient Intervention Comparison and Outcome. The keywords that we used were our patient being a 2.5-year-old with ASD and tactile defensiveness, our intervention being the Wilbarger protocol and sensory integration, comparing it to sensory integration alone, and our outcome being tactile tolerance of water-related self-care activity. The databases that we used were SynAlt Plus, ProQuest, PubMed, and OT Search, and the search terms that we used for SynAlt Plus were Wilbarger protocol and children or autism or ASD or pediatrics, which yielded 3 results and 3 hits. On ProQuest, we used Wilbarger protocol and children or autism or ASD or pediatrics, which yielded 793 results and 30 hits. For PubMed, we used Wilbarger protocol, which yielded 2 results and 2 hits. And OT Search, we used Wilbarger and autism, which yielded 4 results and 1 hit. During our search, we included the following: studies on children, a diagnosis of autism spectrum disorder or sensory processing disorder, symptoms of diagnoses, studies that included Wilbarger protocol or sensory integration interventions. We excluded the following: studies on adults, studies on autism spectrum disorder that focused on alternative treatments, and studies that focused on behavioral treatments. In our research, we found 3 articles under Level 1, 0 under Level 2, 1 under Level 3, 2 under Level 4, 0 under Level 5, and 4 qualitative studies, making a total of 10 articles.
The articles we found for Level 1 evidence are Baranek 2002, The Efficacy of Sensory and Motor Interventions for Children with Autism, Shaw, Benavides et al. 2013, An Intervention for Sensory Difficulties in Children with Autism, a Randomized Controlled Trial, and Weeks, Boshoff, and Stewart 2012, Systematic Review of the Effectiveness of the Wilbarger Protocol with Children. Again, we did not find any articles for the Level 2 of evidence.
For Level 3 of the evidence appraisal, we found an article by Zbigniewski, 2002, The Effects of Sensory Integration's Wilbarger Technique on Engaging Behaviors, a published master's thesis. For Level 4, an article by Bopti and Brown, 2013, examining the Wilbarger's deep pressure and proprioceptive technique for treating children with sensory defensiveness using a multiple single case study approach. And Davis, Durand, and Chen, 2011, The Effects of a Brushing Procedure on Stereotypical Behavior. There were no Level 5 articles for our evidence appraisal.
There were 4 qualitative research studies included in our evidence appraisals. Bayer and Segal, 2006, Integration and Application of a Home Treatment Program, a study of parents and occupational therapists. K, 2001, The Relationship Between Sensory Processing and Self-Care for Children with Autism ages 2 to 4, which was a published doctoral dissertation. Murphy, 2009, Effects of Sensory Integration on Motor Development in K through 3 Students with Autism. And Sudor, 2001, Tactile Defensiveness and the Wilbarger's Brushing Protocol in Symptom Management, which was also a published master's thesis. Implications for occupational therapy practice. We suggest that when recommending the Wilbarger protocol, occupational therapists should consider the type of sensory deficits the child exhibits, because the Wilbarger protocol was not developed to provide types of sensory input other than tactile input. For example, a child with auditory or vestibular sensory defensiveness, rather than tactile defensiveness, would likely not be helped by the Wilbarger protocol. Education of caregivers and regular follow-up are highly important to adherence to the protocol as prescribed, and should be performed by the practitioner in combination with the use of this protocol. After review of the current literature, we recommend that continuing education courses for practitioners be developed for implementation of the Wilbarger Protocol. We believe that occupational therapists would benefit from a more clear definition of the protocol and its components, and more extensive training in implementation of the protocol to improve treatment fidelity among practitioners. Future research on Wilbarger's protocol should focus on decreasing treatment fidelity issues and decreasing the general misunderstandings of the components of the protocol that exist in the current literature. Research can address these issues by using more experimental designs and establishing a single definition of the Wilbarger protocol and the steps of its implementation, so that systematic reviews, the highest level of evidence, can be conducted, and so that intervention studies can more accurately determine the effectiveness of this treatment.